Hi everyone, welcome to the Animal Heartbeat. I'm Jose and Matos, and I'm here with my partner in crime, Kieran and Borgeat. We are veterinary cardiologists and amateur podcasters. We have another special episode today.
We couldn't resist.
Exactly. So, Kieran, what are we doing today?
Anyone who knows the British knows that we love a Christmas quiz. So we decided that we would do the British thing and have an animal heartbeat Christmas quiz. Jose and I have set each other 5 questions of escalating difficulty. So we haven't seen each other's questions yet. I've got no idea what he's asked me and vice versa. The first question is aimed at a first opinion GP vet level, someone who's a bit interested in cardiology and has some experience with cardiothoracic cases. The question that comes second is a little bit harder. It's aimed at somebody who may be doing some continuing education in cardiology. Questions 3 and 4 are aimed at people post-residency or at residency board level. And question 5 is supposed to be almost impossible unless you have a deep knowledge of the case. We've got some very special guests joining us today who I think merit their own introductions. So Caroline, Eve, would you like to introduce yourselves?
Hi everyone, I'm Caroline Cutler. I am Kieran's resident, just entered second year.
My name is Eve. I am a resident at the RVC. I'm also a second year now.
Thank you so much, both of you, for joining us. The plan for the quiz is such that listeners can play along at home. So please see the links in the episode description. Hopefully that will copy across to all the platforms. If not, do email us and we will try and reshare those links. But you should be able to access the images that Jose and I are going to be looking at and the videos that we're going to be looking at, and therefore to see what we're talking about for this quiz. Podcasting is not the most visual medium, but hopefully this is a good way of making it more multimedia. So I don't know about you, I'm absolutely terrified that I'm going to get these all wrong.
I'm very nervous. I honestly feel as nervous as I was when I set my cardiology boards.
Oh boy, more.
Yeah, very, very stressful indeed. And I'm a bit worried that Caroline and Eve would make our life even more difficult.
It's one of the reasons we've asked these fantastic residents to help, is to show us up as being the humans that we are. So before we begin the Christmas quiz, I'd like to say that we're here with a growth mindset. We're going to learn from failure, and anything that we get wrong, we're going to use as an opportunity for study and development later on. And that's the attitude we should all have. So hopefully you'll all enjoy playing along with us. What's the prize? Do we have a prize?
Oh, yeah.
I think it's just honour.
The glory of being victorious in the Animal Heartbeat Christmas quiz. Fantastic. Okay, who's going to go first?
I don't know. I don't know.
I think you should go first.
Okay.
Are you ready, Professor Jose?
As ready as I can ever be. We'll see.
Your first question. So we're going to warm up gradually and get progressively harder. A 10-year-old Cavalier King Charles Spaniel presents with a history of mitral valve disease. It is already receiving pemobendin at an optimized dose. And the owners are reporting an increase in respiratory effort and more frequent coughing. And you have 2 sets of thoracic radiographs to review. And we would like you to describe these thoracic radiographs, and then based on your findings, describe your next steps for case management, please.
So I've given you 3 views of the chest here. 3 views. That's fantastic for a cardiologist, right?
It's too much, honestly. It's too much. I don't know what to do with so many views.
They're not inflating. It's okay.
I'll start by saying that the dog is overweight, and then there's cardiac enlargement. There's a large cardiac silhouette. There is a large left atrium, left atrial dilation. We see that because the trachea is pushed dorsally, and if I would calculate the VHS, which I can't at the moment, but this will be certainly higher than 11 for sure. So left-sided cardiomegaly, dilated left atrium. I think Kieran was cheeky and didn't say anything about. I don't know, he was not. There's mitral valve disease. He is already on pemobendin. Indeed, the X-ray suggests is a X-ray that suggests primary mitral valve disease. So left atrial enlargement, left ventricular enlargement. Then we see compression or collapse of the left mainstem bronchi, especially in the second set of X-rays. The left mainstem bronchi is very squeezed. This is more an expiratory view, and so the collapse is more obvious. So intrathoracic trachea collapse or bronchial collapse is easier to see with expiratory views. And so the left mainstem bronchi seems very, very small. So I think this would be probably the main cause for the dog's cough. So left mainstem bronchial compression, collapse. And again, there's a big debate in veterinary cardiology if this is all caused by a big left atrium plus minus some degree of bronchomalacia, which is common in small breed dogs. But I would think that this dog is coughing due to mainly left mainstem bronchial compression, collapse. I will complain about the X-ray quality and say that both views are quite expiratory.
Hang on. These are X-rays that I took. Are they not? They're not perfect, no?
Suboptimal, I think you would say in English, so they are expiratory. So what I'm trying to say is, I don't see clear signs of left-sided congestive heart failure, but as they are expiratory, there is a bit of a diffuse interstitial pattern, but certainly not alveolar. So I would go that it would be nice to ask the client how was the resting respiratory rate at home, and to see. So I think I will rely a lot on resting respiratory rate to decide if a patient has early left-sided congestive heart failure. But based on these X-rays, I would think that the main problem of this patient right now is this left mainstem bronchial compression collapse, and that might be the reason for the cough and increased respiratory effort. Then the question, what do I do next? How do I manage the case? So there's no magic bullets to treat these cases, and I think each cardiologist will probably have a different approach. So in one hand, we could try to decrease left atrial pressure. This is at the very least a very advanced stage B2. So some people could argue maybe there is already some degree of interstitial pulmonary edema potentially, or by giving furosemide, we could decrease left atrial pressure a bit, and this could relieve a bit of bronchial compression. In the end of the day, I myself end up giving cough suppressors to these dogs, codeine, hydrocodone, to relieve their cough. I would avoid bronchodilators. I'm always very nervous with bronchodilators in dogs with mitral valve disease because I think they get very tachycardic, and I don't think they will help with this degree of bronchial compression or collapse. So that's generally what I do. We could certainly discuss with the clients that we could wash the dog. We could see if there's any underlying bronchial disease, infection disease.
You mean do a BAL rather than a sort of shampoo?
Exactly. Do a BAL. Again, I think depends a lot on how much the owner wants to do and so on, and then aesthetic risk in this patient. Then it depends, again, where you work and your approach in terms of management. I know that probably Kieran and certainly other cardiologists would consider a potentially to I don't know if someone would consider to stent these cases. I don't, but that's, I guess, a potential approach. But I think in this case, with so severe advanced mitral valve disease, I'm not sure that there's an indication. I think that's pretty much it.
Score for this question, Jose, is going to be 4 out of 5, which is a pretty strong start. So the model
still one missing there, Jose. One down on that.
There is room for improvement. Points were awarded for this being expiratory phase of the respiratory cycle because it was taken by a cardiologist, and that this could account for the interstitial pattern that we can see, and you got that point. The cardiomegaly with severe left atrial dilatation is present. There is an absence of an alveolar pattern and marked left bronchial compression, which could very easily account for the cough seen in this patient. And that the approach we would take would be to consider cough suppressants as our first step to see how the dog responded to that. You did miss a mark for not confirming that the pulmonary veins are a similar size to the arteries, and that their diameter does not exceed that of the rib 9 or the proximal third of the fourth rib, depending on the projection that you're looking at.
It's all right, Jose. It's hard sometimes to see the pulmonary vasculature. But
I don't trust pulmonary vessels.
that's controversial. I was sitting here thinking how sickeningly well you've done and how terribly I'm going to do when I see this next question. And I was going to say about bronchodilators, I'm on the same page as you. I don't reach for bronchodilators in these cases. But I've worked with medics who do quite like them for chronic bronchial disease or dynamic airway disease, in that they have an effect of increasing pulmonary fluid uptake and reducing mucus secretion. So they might help to have kind of anti-inflammatory effects secondary. But I don't love that might help versus almost certainly will increase heart rate. And I've certainly seen theophylline give quite profound tachycardia, tremors, salivation, things like that. So it's not something that I tend to reach for. What cough suppressant would you use?
Well, in Zurich, we use codeine. We had codeine. In fact, we had butorphanol tablets, which in extreme case, more tracheal collapse, case with very bad tracheal collapse, either before or after stenting. Butorphanol tablet was great, was absolutely great. But yeah, codeine there, and here hydrocodone. I think it's generally what we use, hydrocodone.
Yeah. We often reach for something like the diphenhydramine based compounds, so lofenoxyl, Lomotil. And I find them a bit more consistent in their capability to suppress the cough than codeine, but I'm not very brave with my codeine dose, maybe.
So I don't see many tracheal collapse cases here because the medics will see them. In Zurich, we saw a lot because we stent and so on. And those cases, our approach was to increase codeine until we see adverse effects, even GI effects, coprostasis or sedation. And so we would keep increasing until the owner felt like the dog is fine, or either stops coughing or is showing some mild adverse effects.
I think just coming back to the stenting question, I have put bronchial stents in dogs like this before, and I'm always slightly terrified of just massively increasing the left atrial pressure, because the left atrium is under such pressure that it's contributing to bronchial collapse with underlying bronchomalacia there. And if you increase the diameter of the bronchus, you squish the left atrium, and that, I think, can trade off in that, that they can result in heart failure. I think there's a small case series from 42 million years ago in the Journal of Small Animal Practice that had quite marked heart failure post-op in 2 or 3 dogs. I've seen it in one case, but in our most recent one that we did, we didn't have that. And that was a big quality of life issue for the dog, not just coughing, but expiratory effort, horrible bronchial collapse, and really his quality of life was so poor that it was one of those situations where you have to be very risk averse to not try. And he did improve post operatively, but they've got a bronchial foreign body by putting a stent in, so they are always going to cough. It's just a matter of controlling the respiratory effort and controlling the cough. So it's definitely not the first thing to do, and I would say 80% of them or more respond to decent medical management. Oh, I'm even more terrified now. Right, okay, good. So
can I just say that I was quite nice with my first case, because I know the stuff you like, and take this as a Christmas present.
This is the gift.
Merry Christmas.
Okay, good. Now if I get it wrong, it'll just look awful, won't it? Imagine that.
Yeah, I think it will. Yeah, it'll look pretty bad.
God, award-winning podcasters, but they wouldn't pass an exam anymore.
So first question for you is a 5-month-old male entire crossbreed dog who's presenting for a cough and increased respiratory rate for the past 2 weeks. Clinical exam, there are increased bronchivesicular sounds, but otherwise normal cardiac sounds, so no murmur or arrhythmia detected. And here are some images of thoracic radiographs taken in said dog. So the question is, what is your radiographic diagnosis?
Wow, okay. Let's walk through. We've got a left lateral radiograph and a dorsiventral radiograph. What I can see is normal thoracic cage, normal looking trachea. It doesn't particularly taper or elevate. It's more parallel in the distal 25% to the sternum than it is to the spine. So that makes me feel like left atrial size is probably normal. Diaphragm looks intact. We're going to come back to the lungs in a minute. What I can see is that, again, I'm not measuring vertebral heart some, but eyeballing it, it looks like it's normal. I can see normal aortic arch. I can see pulmonary vessels, Jose, cranial to the heart in the lateral, and caudal to the heart in the DV. In the DV, I don't think the heart occupies more than 2/3 the thoracic width. Again, supporting my idea that there is not notable cardiomegaly. Okay, the lungs. There is a patchy interstitial coalescing to alveolar pattern in the lung field bilaterally. It's patchy because in the lateral, it appears to be worse in the periphery and worse sort of chordodorsally by the diaphragm. That's where it looks like it's coalescing to alveolar, because I lose the contrast with the vessels caudally. I can't see the aorta more caudally, so it suggests it's quite dense alveolar pattern. And I do think it's present cranioventrally. I can see some air bronchograms cranioventrally as well, as a loss of contrast. It's a VD, isn't it? That's not a DV. It's a VD. And in the VD, I'm saying that because the diaphragm looks different. It looks pointier. There's less contact between the diaphragm and the cardiac silhouette. Please tell me if I'm wrong, because that would be super embarrassing if I make a big deal out of that and I'm incorrect. Again, patchy, increased soft tissue opacity in the lung fields. Again, looks peripheral, sort of worse, very cranial, worse. Caudal, less so in the middle lobes. The pulmonary vessels are obvious. And I wonder if in that VD projection, the artery, which is lateral, veins are ventral and central. So the lateral vessel there, caudally, I wonder if it's slightly wider than the 1, 2, 3, 4, 5, 6, 7, 8, than the 9th rib where it crosses it. So to summarize, we've got a young dog, 2-week history of respiratory signs, including tachypnea and cough. We've got increased bronchovesicular sounds, no murmur or arrhythmia. On the radiograph, we've got normal cardiac silhouette, a patchy, peripherally distributed interstitial alveolar pattern, potentially with some pulmonary artery widening in the VD, not so much in the lateral. Those are my findings. What's your radiographic diagnosis? Well, I guess that's my radiographic diagnosis. What are my differentials for causing it? I have to rule out parasites in this case. So Angiostrongylus vasorum typically has or is reported to have a peripheral alveolar pattern, and it is a young dog. What I would say is I'd have to revise the pre-patent period of Angiostrongylus to work out if the dog was at risk. Do they get transplacental transmission of Angiostrongylus because the dog's only 5 months old? So I'd need to just check in that to make sure it was a sensible differential diagnosis. And now I'm preparing for my imminent embarrassment and demise.
No, you did really well for this one. You scored all 5.
Can I just say, I'm not that I'm a sore loser, but my X-rays are a bit better. The quality of the X-rays is slightly better than the previous ones. Just
how many X-rays have I got there? 2?
Because this call is like, yeah, carry on, Leaf. Carry on.
I will say,
I have time to catch up.
Jose's been very graceful in that he has given you 3 points for naming the most likely differential. And he had 3 answers for the other comments, for which you only needed to get 2 points.
I was working really hard on the descriptors there.
So you got points for talking about the dilated pulmonary artery and the alveolar lung pattern, especially in the peripheral caudal lung lobes. There's also mention here about the right-sided cardiac silhouette enlargement, which wasn't mentioned, but you had 2 points for the other 2, and the most likely diagnosis being Angiostrongylus vasorum, which you got 3 points for. So 5 points in total for that one.
Yeah, he's a generous examiner. Thank you, Dr. Novo Matos. I look back at that. Is it a VD or a DV?
It's a VD.
It looks like a VD. Yeah. The right heart. Now you say it. I kind of see it. The reverse D. You said you don't trust the pulmonary vessels. I don't trust the right heart. unless it's really severe on radiographs.
Yeah, I think there's an increased sternal contact on the lateral view. That's why I thought, yeah, with these X-rays,
Yeah, the apex is a
puppy,
little high
it's
off
like,
the sternum, isn't it? In that lateral,
yeah,
the apex, which is
yeah,
probably
yeah,
right ventricular enlargement. Yeah,
yeah,
all right,
yeah,
I buy it. I
yeah.
buy it. Okay.
Can we take a point? Can we
I would
just
I
give
would
four
voluntarily
to-
give up a point for that, because I think it is there. I think the apex is lifted, and I think there is a reverse D.
Such a gentleman. I just thought to bring these guys because, of course, angiostenosis vasorum is very, very common, endemic in the UK and other European countries, Scandinavia, Germany, Italy, Switzerland. And it's a really important differential diagnosis for pulmonary hypertension because it's a treatable disease. Unfortunately, many other causes of pulmonary hypertension, either we cannot diagnose them or are not treatable. So it's in most cases, a good diagnosis. And as Kieran was saying, as these nearly not pathognomonic, but these very classic X-ray findings, classic of peripheral interstitial to alveolar edema, and that happens because there is pulmonary thromboembolism, hemorrhage affecting the alveoli in the peripheral lung lobes. You could do an angiosnap test. You could still do a fecal exam analysis, either a smear or do a Barman.
I've seen a few dogs with lungworm recently, which I haven't seen that for a long time now. And I remember when lungworm was all new and exciting, and every other dog had seizures or hemorrhagic signs or severe respiratory signs. So, now I'm talking about 20 years ago, that this was very, very common like that, because it was such a novel parasite to most practicing vets. And for me as a new graduate, I was aware of it. We were made very aware of it. Now I don't know if people really think of it as much as a differential, because many of the topical preps are involved in sort of these practice healthcare plans, and people pick them up that way. But I think sometimes we forget about these parasites, and I'm slightly concerned we're seeing a bit of a resurgence, at least in my part of the UK. And I think it would be really good for anyone listening out there to remind any vets who refer to them or any of their colleagues, listen, it's still a thing. Lungworm is still out there. It's still in the wild fox population. It's therefore still in the slugs, the snails, and your dog can pick it up. So it's just worth reiterating that to people, because I think we are seeing a bit of a trend towards a resurgence of it.
I actually have a question for you guys. Apart from sildenafil, obviously for the pulmonary hypertension, if you see it, do you guys often use pimobendin at all, or is that depending on the case, or not at all?
What's your approach, Dr. Pulmonary Hypertension?
So it depends on the right ventricular systolic function. If I see cases, if they're in right-sided congestive heart failure, I'm more likely to combine sildenafil with pimobendin, because then I would think that there is already some degree of right ventricular systolic dysfunction. In case we just severe pulmonary hypertension, no signs of right-sided congestive heart failure, right atrium that is normal, mildly dilated, maybe I would not start pimobendin straight away. But then I think it depends. If I start sildenafil and I don't see any response, then maybe I try to add pimobendin. But I'm not convinced that pimobendin will have a major effect on pulmonary artery dilation.
I think we know that pimobendin makes a difference for post-capillary pulmonary hypertension, where it's secondary to left heart disease. But in those cases, it's increasing left-sided output, reducing regurgitant fraction, things like that. So I think by reducing left atrial pressure there, it makes sense it would benefit the post-pulmonary hypertension dogs. For me, this is an obstructive pulmonary hypertension caused by parasites, thromboemboli, maybe something idiosyncratic as part of the sort of inflammatory reaction to these worms. And I'm not sure I see the rationale for pimobendin in these dogs. Certainly as a first line, I wouldn't reach for it as a first line. But I could be persuaded if a dog's not doing as well as we would want them to, based on the sildenafil, or if it's a dog who experiences GI signs with medium to high doses of sildenafil, which we do occasionally see, I might be more tempted to throw the pimobendin into the mix and see what we can do. Jose, question number 2.
Question number 2 is, what is the ECG rhythm diagnosis for this 6-year-old Labrador that is presented to you for exercise intolerance? This is part A. And part B is, how would you evaluate further And what criteria would you use to determine whether or not you should be prescribing antiarrhythmic treatment for this patient?
So I have a 6-lead ECG, pretty good quality, and
thanks for that.
And quality is great. So we see narrow QRS complexes. I don't know if it is 25 millimeters or 50 millimeters per second. I would go with 50.
It's 50. I'm terribly sorry.
Yeah.
Normally I would supply that information, but yeah. Of course,
I
you could always
get
measure
an
the QT interval,
extra
Jose,
point.
and take a guess based on that.
Yeah. So 50 millimeters per second. So narrow QRS complexes. We do not see P waves preceding each QRS. So this is not a sinus rhythm. So we have narrow QRS complexes, but each QRS is not preceded by a P wave. We then see this phenomenon of the P waves marching in the QRS and out. So we see P waves that seem like sinus P waves marching in and out in the QRS. So they are not associated with the QRS. Heart rate, I can use my phone. And so 5, 10, 15, 3,000 divided by 15, 200 beats per minute. So yeah, tachycardia. So we could call it a narrow, or we should call it a narrow QRS tachycardia with atrioventricular dissociation. So there is no association between the P waves and the QRS. And because the atrial rate is very similar to the ventricular rate, we will call it isorhythmic atrioventricular dissociation. And this pattern that the P waves, the atrial rate and the ventricular rate, or I say ventricular, but it's a junctional rhythm, most likely. So it's a junctional tachycardia. So we have a junctional tachycardia plus the sinus. So we have two rhythms competing: the sinus depolarizations and the junctional rhythm. So junctional tachycardia with isorhythmic AV dissociation. Type 1. So there are two types, type 1 and type 2. Type 1 is when we see the P waves marching in and out of the QRS. The mechanism that is suggested for this to happen is quite interesting, because when the sinus rate is similar to the junctional rate, the atrial kick, the atrial contract against closed AV valves, and so we lose the atrial kick. And so we lose around 20-25% of the stroke volume. So the baroreceptors will perceive that as a decrease in blood pressure. And so they will accelerate, sympathetic tone will increase. They will accelerate the sinus rate. So then the P waves will become a bit faster, and they then precede the QRS. Then the stroke volume normalizes, the baroreceptors decrease the sympathetic tone, and then the blood pressure decreases again. So there is this wax and wane of blood pressure, baroreceptor activation and deactivation, which changes the sinus rate. So yeah, isorhythmic AV dissociation type 1, caused by a junctional tachycardia. It has been interestingly mainly described or initially described in Labradors, classically associated with DCM phenotype. So it'd be nice to have an echo to see if this dog has a dilated cardiomyopathy phenotype.
Always want more.
And then regarding approach to treatment, if this dog is not in congestive heart failure, the dog would be in congestive heart failure, DCM phenotype, congestive heart failure. One could argue, okay, we treat first congestive heart failure to decrease the sympathetic tone, see if we decrease the junctional tachycardia rate. But ideally, we would do a Holter to assess what is the mean ventricular response rate in 24 hours. And based on that mean ventricular response rate, we could decide if treatment is necessary. There's no guidelines on what is the right junctional tachycardia rate in 24 hours. We generally use the same for AF. So if we have a mean heart rate faster than 125 beats per minute, then we would consider treating this junctional rhythm, junctional tachycardia. And so in the past, we have tried calcium channel blockers, amiodarone. I think there's some data in humans showing that junctional tachycardia is associated with mutations in the calcium channels. There was, I think, an abstract at ECVM once, but I don't think that paper was published in dogs. Most recently, Roberto Santilli mentioned in a forum that he uses ivabradine. And after we heard that, we started using ivabradine in these cases. N of 3, I think 4. I think maybe we have 3 or 4 cases. And at least in these 2 or 3 cases. After dose adjustment, so we start with a rather lower dose, repeat halters, as we do with any SVTs or ventricular arrhythmias, then have increased the dose, and with good response. So at least when this reduced amount of cases, ivabradine seemed to have worked to decrease the junctional tachycardia rate. So we are doing right control. Generally, they don't go back to sinus rhythm. So we are not doing rhythm control, but right control. And yeah, now that I'm worried I will have missed something and I will not have my 5 points. But I think, let me see, prescribe antiarrhythmic. Yeah, I think that's it.
It is a gold Christmas star. That is definitely 5 out of 5.
Yes.
Hitting all the model answers. So identifying that this is AV dissociation, it is isorhythmic with type 1, and we've got a narrow complex tachycardia that is suggestive. Oh, I'm not sure you actually said focal junctional tachycardia. Did you?
I think you did. Yeah, I mean, I think we can take junctional tachycardia there. That's okay. It's okay.
I don't be too picky, Caroline.
Imagine what it's like working with her.
You also identified, or your plan for further evaluation was that we should perform an echo, and that really our question to treat would be primarily based on our Holter assessment of our mean heart rate. So 5 out of 5. I did want to ask you about your experience of ivabradine in dogs with mild atrial enlargement. So I know Kieran's had experience of worsening of left atrial pressures, even if there's any mild left atrial dilation for dogs on ivabradine. And I wondered if you'd seen anything like that.
That was exactly the question I was going to ask. And actually, I think I've treated maybe 4 as well with ivabradine. I'm not sure I understand the rationale for it, in that the currents, the hyperpolarizing currents in the sinoatrial node are really the target for the ivabradine. And we're not that interested in the sinoatrial node here. We're interested in the junctional rhythm. However, in humans, there's definitely data showing that ivabradine can control AF rate and reduce AF rate. But in people, ivabradine does increase the risk of developing AF. And all 4 of my dogs that I've treated with ivabradine for this rhythm, or Labradors, or middle-aged, have developed atrial fibrillation. Now, would they get atrial fibrillation anyway because they've got heart disease? Maybe. I don't know. So n = 4 is nothing. But I think it's a really interesting question to sort of share our experiences of these. And I'd love to know what your thoughts are on it.
There is, in fact, it's a bit contradictory, the data in humans. In one hand, there are data showing that ivabradine can cause AF, but ivabradine is also used as a rate control drug in AF in people at times, as you mentioned. So one of our dogs
come out as being successful in a meta-analysis. So it suggests that's real, that it does help rate control in AF.
But we faced that problem with one dog, but he developed AF, I think, after 6 or 7 months of being in ivabradine, and the left atrial size increased. And we thought, okay, maybe this was just natural disease progression. And then when he did that, we were like, oh, should we keep ivabradine or then stop ivabradine? And then as we are more experienced in using diazepam with digoxin as rate control drugs, then we stop ivabradine and swap it to diazepam and digoxin. But I don't know if Roberto Centil is indeed doing a study on this or not, but it would be really nice. It would be really nice to have a large study with a proper number of cases to see how these cases progress over time.
I think it'd be really interesting to look at the ivabradine treated versus ideally an equal number or more, like a case control series of dogs treated with non-ivabradine treatments. And it'd be really interesting to know what the incidence of AF was, and we could do it with that sort of case control. So Roberto, you probably don't listen, but Roberto, if you're listening, it'd be great to reach out and talk about it, because I think, this is a super interesting arrhythmia, and one that we see enough of that it merits a bit more information about what's happening. And if Dr. Santilli already has the data, great, fantastic work. We're looking forward to the publication. Okay, Eve, great. I'm ready.
Question 2 for you. A 9-month-old male entire Cocker Spaniel who is presenting for a 5 out of 6, grade 5 out of 6 left basilar systolic heart murmur. And there is then a cine loop of an echo. And the question is, what is your echo diagnosis?
I've not pressed play yet, on the cine loop, but I can see one cine loop asking me for my diagnosis of an echo. This is like asking someone to climb Everest with a hand tied behind their back. It's challenging. That's challenging. I like it though. I'm here for that. Okay. Let's see if
He's
it plays.
so worried to get it wrong that
Jesse, I didn't sleep last night. Oh.
You see, again, I was really nice. Friendly.
Yeah, all right. I mean, yeah, it's a good cine loop. Okay, so we've got a right parasternal long axis view, which is optimized to the mitral valve being centered. I can see the both left and right atria fairly clearly, and the tricuspid and mitral valves, or left and right AV valves, quite nicely. Can't see the left ventricular apex, but probably that's not an important part of this case. Looking at the simultaneous ECG, the heart rate reportedly is about 108, so it's not too tachycardic or bradycardic. It looks like we're in sinus rhythm with a right axis deviation, by which I mean deep or prominent S waves, which makes me think about right-sided cardiac enlargement. Looking at the right heart, it does look like the right heart is large. It looks like the right ventricular free wall is hypertrophic. It looks like the chamber size of the right ventricle is also a little bit large, and the right atrium, eyeballing it, looks like it might be close to the same size as the left atrium. Let's look at the left atrium. It's nice and angular and square. Nice pulmonary vein coming into the roof. Mitral annulus looks normal, and the mitral apparatus looks pretty normal. The tricuspid apparatus looks thick and strange. It doesn't look as if there are nice chordy tendons on that tricuspid valve, or if they are present, they're rather short. The septal leaflet of the tricuspid valve, I want to say looks tethered, but I mean, tethered is, it's a horrible term for describing the tricuspid valve, which is weird anyway, and has a wide spectrum of normal variability. But I don't think there's much chordy tendon on the mural leaflet of the tricuspid valve that I can see. So I'm going to say there might be some tricuspid dysplasia. The right ventricular hypertrophy and the history of the left basilar murmur makes me think about something like a pulmonic stenosis or a double chamber right ventricle. I think given the descriptors and the relative probabilities of those two, probably pulmonic stenosis is more likely. And here, obviously, I've not talked about it yet. We can see a bubble study. So we have the bubbles coming back from a venous injection into the right heart. We can see them entering at the atrial level, and we can see them shunting at the atrial level from right to left, which suggests increased pressure and reduced compliance in the right ventricle. So to me, I'm going to say that we are likely to have a pulmonic stenosis or potentially a double chamber right ventricle. I'm going to say I think there is tricuspid dysplasia in this case. Although I'm very conservative about making that diagnosis. And there's a right to left interatrial shunt, which is either going to be an atrial septal defect or a patent foramen ovale. And again, thinking about relative prevalence of those different problems, it's probably a PFO secondary to increased right-sided pressures.
Cool, very good. So there aren't any specific marks for this, so I've come up with my own a little bit.
Excellent. Good initiative.
I think you have gotten everything. The only thing that I would have thought would be good to mention is, although you don't have the pressure gradient across the pulmonic valve, but as an assumed
fair point. We're going to assume it's severe.
Based on, yeah, are you going with severe now? We'll give it a half point because that was after the time allowance. But
all right. No, I love it. Okay, yeah, good.
There was no image of the pulmonic valve, which seems a little bit unfair in a pulmonic.
Yeah, that is a bit unfair.
But am I right? That's what matters. Was it pulmonic stenosis? And what do you think about the tricuspid valve?
Severe pulmonic stenosis. We still don't know if it's a double chamber, but Jose has put here severe pulmonic stenosis with a PFO. And the saline bubble study shows a right to left shunt at the atrial level, as you correctly identified. And the fact that there was also the shunting within the first 5 cycles. So it starts to shunt within the first 3 cycles in this case. There's no mention about tricuspid valve dysplasia here.
I'm conservative in diagnosing it, but it looks like an abnormal tricuspid valve to me. What do you think, Jose? I'm not sure it's the alligator closest to the boat here, but I think it is an abnormality.
Yeah, I agree. I'm always conservative and a bit defensive about diagnosed tricuspid splenitis. This, you didn't have enough information. This dog had only mild tricuspid regurg. I agree. The cardiac tendinous seems short and so on. But I'm always very careful, and I generally only make that call if I have at least moderate to severe tricuspid regurg and a very abnormal tricuspid valve. And then I would rather wait to see what happens after balloon valvuloplasty. Indeed, you could not know what was the cause for right ventricular pressure overload. Could have been double chamber or pulmonary stenosis. Was a pulmonary stenosis. We call it a PFO because I think with PFOs you generally can see the two. If we look carefully, you can see the two membranes. Look like a little bubble to me.
Yeah, it's like a flap, isn't it, rather than a hole?
A flap. To suggest that indeed you have the septum primum and the septum secundum that have not fused. And just for our listeners, doing bubble studies, is important to stress that after right atrial or right ventricular pacifications, the bubbles should appear in the left heart within the first 5 cardiac cycles, because that's the pulmonary transit time. Because if they show up later than 5 cardiac cycles, that would suggest an arterial-venous connection, a pulmonary arteriovenous communication, connect the pulmonary artery to the pulmonary veins. Yeah, you did very well.
So
thanks very much.
4.5 points for that one.
4.5. Oh, I'm half a point behind by my reckoning. Not that I'm keeping score. Fantastic. Right, Jose, I believe it's your turn. And let's not forget, for the listeners, these questions are getting more intense as we go, more challenging as we go. So if you're playing along and you're finding it hard, that's all right. You know, Jose's might find this hard as well.
I am. I think the next one. Yeah, it's going to be a difficult one. Okay, Caroline, tell me.
It's going to be fine. It's going to be fine. So, question 3. A 3-year-old female neutered collie cross dog that has a history of pulmonic stenosis and was treated by transpulmonic stent angioplasty successfully. And she has been very well and asymptomatic for 2 years post-procedure. But on her current check, you have identified that there's an increase in pressure gradient on her echo. And her owners are also reporting that she has some reduction in her exercise tolerance. So what you have here for this dog is a thoracic CT in the soft tissue window. And we would like to know what the main abnormalities that you can see, please.
I just wanted to say that we should say pulmonary stenosis, not pulmonic. So but that's okay.
You've been talking to Brian again, haven't you? Sorry, Caroline, your mentor has trained you badly.
So you also wrote Pima-Bendon wrong on the first slide, but I was going to mention it.
That's autocorrect on the Mac. It autocorrects.
So great. So I'm very nervous indeed, because I honestly very rarely look at thoracic CTs. But yeah, so I'm looking at, as Kieran said, soft tissue, a window, a transverse section of the chest. We see the stent in the right ventricular outflow tract. Is not an angio CT, so difficult to identify the different chambers. But I would say that the right atrium seems dilated. If you're difficult to assess the severity, cannot assess the severity of RV, right ventricular hypertrophy. The stent closer to the RVOT, to the right ventricular outflow tract, is narrow, which I think my first suspicion would be that there is a stent fracture. I guess it'd be nice to maybe to see it in different planes. But so just to describe to the listeners, what I'm seeing is the stent, instead of being a perfect tube cylinder, it is narrow. The edges are closer to each other in the RVOT area. And so I think I would think about a stent fracture, which could be the reason why now there is an increased gradient again. Yeah, I think so. The CT findings, as expected, as this dog must have severe pulmonary stenosis. I think the right atrium seems very, very big. The right ventricle is enlarged, but difficult to know, cannot comment on how much hypertrophy and/or eccentric hypertrophy there is. Pulmonary artery branches seem fine, dilated, but otherwise fine. And for stuff like this, I don't know, stuff that I would think if I have a stent or I do a balloon valvuloplasty and then the gradient increases, it would be either restenosis or rare stuff like dissections and so on with a stent fracture. for those other differential diagnoses, I would need an angio-CT. So I don't know. I feel like I'm missing stuff, but I would go with a stent fracture. Yeah, I don't have much more to say. I have to be honest.
So the questions are getting harder. So I don't want you to be disappointed with your score.
She's good at sugarcoating. That's a good sugarcoat.
Very good, thank you.
So the model answer, which is of course debatable, first of all, there's no evidence of pulmonary infiltrates, which is probably a really important question to ask in this dog. And you didn't mention that.
Is it? Why would that be important?
I think because there was yeah, maybe not.
This is a dog with pulmonary stenosis. Why would I expect to have pulmonary
to be fair, it's there for completeness. It's there for completeness. So
Okay.
I'm open to negotiation. I'm
Okay.
open to negotiation.
What is common is common. Yeah, there is
Yeah,
an
but
increased pressure gradient.
images
Why would
about
there be? Why would there be an increased pressure gradient? If you
And
would have...
to be fair, if you look in the left lung, there's a little bit of atelectasis, which I guess you could say you don't know that there's not some pulmonary infiltrates there. So actually, maybe I should leave this to the examiner's decision, Eve and Caroline, to review this and let us know what your thoughts are. I'm not gonna overrule anything.
Okay, so should we modify the scoring system on this one?
You can do what you like.
Okay, it's going to be very hard to then work out. We'll have to work out a percentage point then, but we can do that. We can do that. Okay, so we'll move on to the other point. So the right heart is dilated, but also so is the vena cava. And the conclusion we need to draw from this is that this dog is at risk of heart failure, right-sided. So we didn't have that conclusion. So I think we need to deduct half a point for that. You did correctly identify that the stent was in position across the RVOT where it should be, and there is some narrowing at the proximal end. I don't think you mentioned that there was some embolization of that stent, and some of it is located in the right pulmonary arterial branch.
No, absolutely. No, I missed that. No.
I definitely didn't hear that. I definitely didn't hear that.
Sugarcoating.
That's okay. The pulmonary infiltrates, I would not accept to have points deducted on that. But
the embolism is an important part of that. It's fractured. Where did it go? Is there stuff missing?
Yeah, so I think that is something that is important to diagnose on this CT. Not necessarily that we're going to go and remove that bit of embolized material, but it helps, I think, confirm our diagnosis that we have had a stent fracture here, and makes us feel confident that we've explained the clinical signs that we're seeing in this dog. Eve, I don't know where you got to on a score. Do you think 3.5 out of 5 is fair as a?
Then we should do a 3.5 out of 5 as opposed to 3.5 out of.
I would appeal at the end, but yeah, that's fine.
There's no committee. It's a Christmas quiz that we are not taking seriously.
Okay. Merry Christmas. So that's fine. 3.5.
3.5.
No, that's fine.
Okay, good.
This could be quite a nice point to talk about the approach to these.
I think these are tough cases because we do see them, and I've certainly seen a couple of cases. I've been doing transpulmonic stents now since 2018. I did the first cases then, and so I have 6.5-year outcome on one dog, and then sequentially less on others. Seen a couple of cases now who have experienced apparent restenosis, and in this case here, there was a stent fracture proximal in the RVOT, and there was embolization of material confirming that. And actually, if you get fancy, you can reconstruct that CT, and you can see that there's material missing, that there's incomplete rings. In that case, it was obvious it was a fracture. In the previous case that I'd seen, it wasn't obviously associated with a fracture, but there was some flattening of the stent or some crimping in the stent of the RVOT at the time of stent deployment or during the first procedure. I don't think it fractured. But what we did with both cases was perform a stent in stent, like a salvage procedure, where we put a different stent, a harder, different material in that stent and overlapped it with the previous one. So we tried to stabilize any pieces that had been damaged or might be unstable there and reduce the risk of further embolism. But also we managed to open up the outflow tract in those cases. I don't know how common that is. We're writing up stent outcome at the moment, and it'd be really interesting to know what the prevalence of that is amongst the stent dogs and if we can identify any risk factors. But that's how we've approached those. I think sometimes there might be fibrous tissue ingrowth or granulation tissue associated with fractures or damage, which can potentially cause restenosis in the absence of overt metal fracture. But I think they can be challenging, and watch this space. Hopefully there'll be more data coming out in the next 12, 18 months about these dogs.
Very cool. Thanks.
Cool. So
I feel like
good.
yours are about to step up in difficulty.
yeah, for sure. The next one is a bit of a show of all the different modalities they have at Cambridge. This dog has had all sorts of images. There's an echo, there's an angio, there's a cardiac MRI, and also pathology. So case
I have to
three.
say, I'm sorry to interrupt. I have to say, this was done in Zurich, just to be fair to the Zurich imaging group. Yeah.
Oh, it's going to be a tough case when you've held on to it since Zurich. Boy, oh boy. My adrenal glands are contracting, or whatever they do. I don't know.
So this is a 2-year-old female entire Airedale Terrier who is presenting for exercise intolerance, cyanosis during exercise, and tachypnea. And as I said, there are different modalities. The first one you can go through, the first slide shows different echo cine loops.
Okay, wow. So we've got 6 echo cine loops on the first slide. All right, I'm watching the one in the top left currently. Looks like the left heart, subjectively eyeballing it, looks normal. The right heart looks like we've got normal atrium AV valve, shape and size of the right ventricle compared to the left. But between the right and left atria, it looks like there isn't a third chamber or an additional chamber or vessel in there. So now looking at the middle echo loop in the top row, we've got something close to a left apical 4 or 5 chamber view. We've got a little bit of outflow tract on there. We've got a bit of a right heart prominence, but it's optimized to show this additional structure between the left atria and the right atria there. So top right image, we've got the echo loop. Okay, so we've got a right ventricular inflow outflow view here from the right parasternal window. I'm guessing it may also be from a left cranial. Is it? No, it must be right parasternal short axis. The aortic valve is in the center, pulmonic valve to the right of that, and you can see the pulmonary artery extending down from there with the bifurcation. So if we look around the tricuspid valve at the top left, we've got the right atrium, and then there's what looks like a sort of membranous structure within that right atrium, which may be associated with that third chamber that we are seeing. And at the bottom, we've got the color. So we can see the color of that right parasternal long axis view showing flow towards the probe from that additional structure, that third chamber, if you like. It looks like it's entering the right atrium. I don't think it communicates with the left based on this. Then we've got that slightly modified outflow tract view from the right parasternal window this time. And we can see that membranous structure into the right atrium, which looks as if there's an orifice in that membrane entering into the right atrium. And then the image in the bottom right, again, it looks like there's flow through that orifice into the right atrium. So now, I'm going to say my working diagnosis, not my final diagnosis, my working diagnosis based on the echo that I'd be thinking about would be a divided right atrium, specifically, to use the terminology that I really dislike because it's Latin terminology that doesn't help us communicate necessarily what's going on. Core triatriatum dexter would be my working diagnosis. So a divided right atrium and persistence of the right valve of the sinus venosus. Now, it looks like it is communicating with the true right atrium. Oh, right, we have a bubble study. Fantastic. Okay, good. Let's have a look at the bubbles. Okay. Oh, I've changed my mind. This is a view looking at it's sort of a left-sided view. We've got the left atrium to the right of the screen here, the right of the cine loop, left ventricle at the top. And we've got this atrial structure at the bottom. So I'm just going to go through frame by frame. Very early on, I can see bubbles from a peripheral venous injection entering the left atrium. Simultaneous, or maybe slightly earlier than they're obviously entering the right atrium, which is not typical for a divided right atrium, a core triatriatum dexter. And I can see negative contrast later in that cine loop. I can see negative contrast coming into the right atrium from this chamber. Ah, fascinating. All right, I see why we have multiple imaging modalities. If you're not sure, find out. Look harder. So, okay, whoa, look at these angio images. This is a. I'm going to take a time out, Jose, and say this is a cool case, right?
But the quality is pretty poor. I have to say, this was a hand injection angio.
I love a hand injection.
And just to say that the quality is poor. And so, besides the video loop, I've given Kieran 2 steel frames of the angio because the video, yeah, the quality is not great.
All right,
yeah.
okay, good,
Sorry.
good excuses to get in there. Oh yeah, it's quick as well, right? I mean, it's a fast injection. Okay, we've got a catheter, presumably coming from a jugular vein and entering this venous or vascular structure, which, oh boy, which opacifies and enters what looks like the left atrium dorsally. So I'm just going to go through frame by frame on this angio. Does it enter the right atrium as well? Yeah, it does. So this looks like it comes from the cranial vena cava. And the contrast injection there does empty into the right atrium via the cranial cava, because I can see the right atrium, tricuspid valve, right ventricle opacifying. But then there's this vascular structure which just looks like it dumps right into the roof of the left atrium. Now, if you showed me the course of the catheter without showing me the injection, I would say, oh, you're in the azygos there. So I'd be thinking that position would be an azygos vein. And if I go through frame by frame, I think I can see, after that arch opacifies, I think I can see some backflow into another vascular structure, which would be more typical with the course of the azygos. So my money based on these is that we have got an azygos vein which has an aberrant communication with the left atrium and the roof of the left atrium. God, what else have we got? All right, cardiac MRI. Okay, let's watch this. Don't do these every day. Nice pictures though, eh? Okay, so it looks like we've got orthogonal views here. Pretty much. We have got a view looking from the thoracic inlet caudally on the left, and on the right, we've got a lateral plane view. Boy, oh boy, I'm going to have to go through frame by frame again. So we can see contrast opacify in the right heart, I think. Let me go through frame by frame. So probably we've got a peripheral vein injection. We've got the right heart opacify, the pulmonary artery and its branches. The left heart is visible there. And we can see as we go through that, what it looks like we've got normal aortic. Is that normal aortic vascular structures? Oh, Jose, you're killing me. I can't believe this is not case number 5. I wish I remembered my embryology better.
Don't worry, you have spot pretty much everything, or if not everything. So don't worry.
So based on what I can see, I'm just trying to work out if this communicates with the aorta or not, because I don't know where the injection was. I'm presuming it's a peripheral vein injection, but just in some of this MR angio, if you like, it looks like the descending aorta communicates with this vascular structure, which then dumps into the left atrium. But if we follow that through, we can see the cranial cava opacifies around the same time as the aorta. And I think it can't be the aorta. It can't communicate with the aorta, just clinically. There's no way, because the left heart wouldn't tolerate it. It would be absolutely destroyed by that flow. So surely this has got to be a communication, cranial cava, azygos, and then probably a better term for it, but a communication, a vascular communication, like a persistent something azygos that connects into the left atrium or the left pulmonary veins. What else have we got? Okay, I'm dreading what's next. Oh my goodness. It's just, there's more. How many images have you provided me with?
No, those are just still frames. I should have told you. We have still frames of the MRI.
So we can see some vertebral veins draining into this this arch-like structure as well, and I do think it's venous. I don't think it's aortic. So I think it's something to do with the azygous veins communicating either with the pulmonary vein or the left atrium. Dog clearly didn't do very well. We have gross post-mortem specimen, and on the gross post-mortem image on the left is again looking sort of lateral cranial to the right of that image, caudal to the left. We can see the caudal cava. We can see the cranial cava. Yes, it looks like it's the azygos, doesn't it? And then it communicates via this abnormal vessel into the pulmonary vein ampulla that empties into the left atrium. The image on the right, does that show a sinus venosus ASD? Which might explain, if this was a sinus venosus malformation, it might explain why the azygos communicates with either the pulmonary vein ampulla or the left atrium. So my diagnosis, my final diagnosis, is this dog had a very strange congenital malformation, which involved its veins, probably its azygos, emptying into its pulmonary veins left atrium.
Anything else that you mentioned from the echo? It might be a while ago, so you can go back and have a look at it.
And the right atrium. What did I make? Are you throwing me a bone here? Do I need all the help I can get from this? So I said I thought there might be a cortra atriatum.
Yeah.
And yeah, there is that. Could that just be the vessel? That I don't think it has to be a cortra atriatum. Actually, I think that could just be the part of the same malformation, which is a sinus venosus malformation of some sort. But I'm not sure I'd label it a cortra atriatum because I don't think there's a pressure gradient across that membrane so much. And I guess it's semantics, isn't it? You could say there's a cortra atriatum dexter with communication with the azygos and blah, blah, blah. Or maybe it's just part of the same malformation. I don't know. What gives me the most points? Maybe there's a cortra atriatum with an abnormal azygos communication with the left atrium. There we go.
So there were a lot of, to be honest, you actually did a pretty good job.
Thanks.
I'll take into account everything you said throughout. So you got, and in terms of the diagnosis listed here.
Trying to reassure myself throughout.
I wonder if Eve I think Eve is a bit nicer than Caroline.
You're going to raise allegiances here.
I think Caroline is really picky. Like, no, you didn't say this.
Listen, Caroline is we have a growth mindset in our team. You know, we learn from failure. She knows that I take constructive feedback in a positive manner. So
we also aim for high quality. So
oh yeah, always quality.
So that's my problem. Okay.
Jake.
I don't know what you mean about the angiogram. I think that's quite a nice injection, actually. When you walk it through, you can see everything you need to see. Unless I got it totally wrong, in which case I'm blaming the angiogram.
So yeah, you noted the aberrant azygos vein emptying into the left atrium. The fact that there was a core tracheatum dexter. Here is also listed plus or minus persistent eustachian valve. And in terms of the interatrial shunt, at least with the answers listed that there's a PFO, so a patent foramen ovale, with the right to left shunt.
Is that what you're seeing at the end? That's the last image, isn't it? On the that's the last image on the path. Yeah, all right. There's a PFO. Fine.
On the bubble study, you see that there is a PFO, and then that the contrast and the negative contrast, as you were saying. So I think it goes left, right across the PFO, and then there is contrast also arriving from the roof of the left atrium. So a PFO classically is right to left. That's all is right to left. A PFO is right to left. That's what the PFO is for. So it's right atrium, left atrium. Now you could say it can never be left to right, but that depends a lot on the size of the flaps. And in some PFOs, the flap may invert, and you may have left to right. So a PFO by definition should always be right to left, because that's why embryologically it should be. And the way that the septum are done, they will be always right to left. If the left atrial pressure is higher, the septum primum will close against the septum secundum. So it should always be right to left, but I think you do see cases that go left to right as well, depending on how dilated or apart the septa are.
On the morphology of the foramen. Yeah. Okay. All right. Fine. What's the verdict?
Cool.
I think that was very mean. Question 3.
Where's he going to go?
It was
So hard.
That's a harsh one for sure.
Yeah.
So the only thing is, in my defense, this has been published. And so you could say, okay, this has been published. So
by definition, it should be a question 5.
I am not saying that I don't take this seriously. But who's got time to study for a Christmas quiz?
True.
Guys,
But you are an intervention guy. I wanted to give you some challenge, contrast stuff.
I love a challenge. I love a challenge and a
Good,
multi-imaging modality. Guys, listen, people have been listening for, I don't know, 12 million years now, and we're still on question 3. So I think we should have a break in the episode and make a part 2. Is that controversial?
No, that sounds like a good idea.
Okay.
You had yet to hear how many points you got for that question, though.
Oh, can't we? Let's have a cliffhanger.
Give you that first. So I gave you
cliffhanger. Don't tell me. Tell me at the start of the next episode, which for us will be in mere moments time recording this, but for the listeners will be Boxing Day.
Amazing.
So, listeners, don't hold your breath. Be excited. Enjoy the rest of your Christmas day. We sure will. And be sure to stream the second part of our Christmas special tomorrow. So let's say goodbye for now, everybody.
Goodbye. Merry Christmas.
Merry Christmas.
Bye-bye. Happy Christmas, everyone.
And we'll see you bright and early Boxing Day morning to find out, well, what score I just got on the hardest quiz question ever, Professor Matos, but to find out who is the ultimate winner of the Animal Heartbeat Christmas Special Quiz.